Hello, this is the presentation and overview of mental health services, structure, and the referral process for the 2021-2022 program year. Some of the slides may reference certain handouts, so if you're viewing this after pre-service and are in need of those handouts, please send me an email so that I can be sure to get those to you. My contact information will be on the final slide. Here's our agenda for today. We'll spend our time covering the basic principles of infant and early childhood mental health, the organizational structure of the internal mental health services, a crosswalk of support to better understand what role can support each need that may occur, and finally, we will go over the referral processes for behavioral and mental health support services. So first, I'd like to define a term that's going to be used quite a bit throughout this presentation, which is early childhood mental health consultation. It's abbreviated as ECMHC. So early childhood mental health consultation is an indirect intervention in which consultants work with teachers, parents, and administrators to build their capacities to promote healthy social emotional development and to address challenging behaviors. Most of the consultant's time is spent with adults on behalf of young children. Often, consultation is sought when children demonstrate challenging behaviors. Early childhood mental health consultation may directly enhance adults' abilities to foster children's emotional and relational well-being. In turn, young children's behavior and self-regulation may improve. Consultants do this by working alongside the early childhood professionals in their daily settings, sharing strategies, modeling evidence-based intervention approaches, facilitating referrals, and cultivating a deeper understanding of the factors that shape young children's social emotional development. So this is a model that we are adopting this year. It is based out of the Georgetown model for early childhood mental health consultation. This is the framework we'll be using to provide our services. Now we're going to begin our overview of what infant and early childhood mental health actually is. So infant and early childhood mental health is both simple and complex. It is defined as a child's emerging ability to form close and secure adult and peer relationships, to experience, manage, and express a full range of emotions, and to explore their environment and learn. In other words, you may have heard this referred to as social emotional development. The complexity arises in the consideration of the child's family, culture, and community, which all influence and shape what is considered to be either healthy or typical social emotional development. So it's really critical that when we are staffing a child or an issue surrounding a child's well-being, that we do take into consideration what is normative in this child's culture, in this child's family. We want to hold them to a standard that is appropriate for the context of their family, their community. So we want to place the bar of healthy or typical at a realistic expectation for what we can expect from their own personal lens of the world. Our early experiences are one of the most critical aspects of brain development. These early experiences shape and influence our brains and can provide the foundation for how we sense and perceive the world. We can see evidence of this in newborns who learn to trust or mistrust by crying, and then depending on the quality of care they receive, will teach them how to perceive the world in a trusting way or in a non-trusting way. This is also an example of how critical relationships are to influencing our brain development. Children see the world through the eyes of their attachment figures, and they learn about their relationship with the world through the experiences and relationship quality they have with these key people. It is also important to remember that behavior is simply a form of communication, be it an expression of a need or of a deficit in a social skill. So we can address the externalizing symptoms, the behavior itself, or we can look at the underlying need that's being demonstrated by this child with the language that they lack, or providing them the skills that they need, and hopefully getting to that root cause will extinguish the negative behavior that we don't want to see. So children are still developing the capacities to effectively communicate the broad array of emotions or feelings they experience, sometimes for the very first time ever. So additionally, based on their age and development, they may have a limited capacity to control their impulses or lack the skills to regulate themselves independently. In early childhood care, being a trusted adult who can join in co-regulation, modeling, labeling emotion, and being a safe haven for those big emotions is critical. As early childhood providers, we must not take for granted that each child in our care is typically developing. While it may be a relatively straightforward path to identify organic causes of atypical development, there can be quite a bit more gray area when it comes to development that has been influenced by experiences of adversity or trauma. Oftentimes, a child's brain that has been affected by experiences of trauma or adversity can respond to environmental and relational cues from the brainstem or the limbic system, and this can show up as negative behaviors. So you can see this conscious discipline brain state model over here, and when we talk about the brainstem or the limbic system, we're referring to the red and the blue parts of the brain, which control the survival system, so fight, flight, or freeze, as well as the emotional state of the brain. A child seeking connection may use hostile or inappropriate tactics. A child whose brain has been wired for survival and safety may automatically perceive their environment and relationships as dangerous or threatening and respond accordingly. Additionally, areas of the brain that we may expect to be developed can in fact be underdeveloped. So commonly this might show up as impulse control issues or emotion regulation challenges. These are all really important things to keep in mind when working with the children in our care, taking into consideration not just where they are chronologically in their age, but truly developmentally based on their life experiences and their developmental domains that we measure them on. We're going to take a look at the organizational structure of our internal mental health support services. So it is important to know when and how to access mental health support services. Sharing the overview of early childhood mental health should assist with the when, and understanding the organizational structure should help with the how. Mental health staff are housed under comprehensive services in Children First. So as indicated in the intro, beginning this program year, we're going to be using the Georgetown model for mental health consultation as our framework for service delivery. The mental health team will consist of 2 consultants and 1 mental health therapist. Currently in those roles are myself, Arianne, for North County, and Susan Miller for South County. We're in the process of conducting interviews for the mental health therapist, so you'll be updated as soon as we have an update to provide. The consultants will work primarily within the context of the classroom setting, as well as providing some support and developmental guidance to families. The therapist will conduct the direct therapeutic service with the child, and in most cases also the parent. This work may be done on site, in the home, or in the community. So here is a visual of what was just described. At the top of the list is Wendy Harris, the Director of Comprehensive Services, who oversees all of the service providers and coordinators in comprehensive services. Beneath Wendy is myself and Susan for North and South County consultation. And then we also have the mental health therapist who is coordinated by the consultant role. And their name will be updated as soon as we have one to put in there. And now we're going to talk about how all of the great support systems at Children First kind of interact with this mental health consultation model. So it's important to be clear, the role of a mental health consultant is not a supervisory role, and it's not meant to replace supervisions with your manager. All work done by or with the consultant is with the goal of supporting the relationship and attachment quality between the child and the caregiver. This may look like targeted training or professional development based on individual or team needs, regular opportunities for goal setting and planning, reflective consultation, and targeted support in the classroom, such as modeling recommended techniques or skills, behavior planning, etc. The philosophy that this is rooted in is that of parallel process. So if educators and caregivers are supported in their professional capacities and needs, they can go on to support the children in their growth and development. So this role is clearly meant to be collaborative with educators, with administration, and with the variety of support roles within our program. Collaboration often will occur with special needs coordinators, early childhood coaches, the mental health therapist, health and nutrition staff, family advocates, and of course the family or caregivers of the child. Each person listed has a unique contribution from their own lens, so be that development, curriculum implementation, health factors, socioeconomic factors, or personal and family level considerations. As we probably all agree, a holistic approach to care often achieves the best outcomes for children. So that's why it's really critical that all of these roles have a piece of the puzzle when it comes to caring and supporting for our children that have maybe extra needs or different needs. The mental health consultation model also aligns with the PBS pyramid model. So if you're unfamiliar with the pyramid model, it is a framework for influencing a culture and environment of positive social, emotional, and behavioral development within an organization. Under the pyramid model, mental health consultation has concentrated efforts in all levels of the pyramid. Consultants work with administration to influence and support a system that promotes an effective workforce. They also work within the first tier to promote high-quality learning environments. They support the second tier by offering targeted supports to children or classrooms with identified needs. And they support the third tier by facilitating referrals to mental health care, as well as supporting teachers in the skills and training needed to respond to these high-level needs. So some examples of what you as a teacher might expect from working with us as consultants this year includes monthly classroom visits, regular opportunities for reflection, training in social and emotional trauma-informed practices, conscious discipline implementation support, support for children and teachers based on the needs identified through ASQSEs or personal social domains, behavioral needs, social emotional development, and attendance at classroom staffings. And now we'll discuss how to obtain a referral for either behavioral needs or mental health support services. A child in our program can be referred to our internal mental and behavioral health supports for a variety of reasons, including but not limited to concerns identified using the ASQ and ASQSE, challenging behavior in the classroom, or deficits in their social emotional development. While the mental health team tackles this transitional phase that we're in, any referral for mental health or behavior support will be submitted to me, Arianne. Using the drop-down menu in Kopacz, select from the highlighted options identified in the picture the appropriate choice based on the child's center. Once a referral has been submitted, I will triage it and coordinate the follow-ups as needed. We ask that for the accuracy and thoroughness of our record keeping, please do not submit referrals to the behavior support specialist option. It is likely that your referral will not be received this way. So if you've been with Children First for some time, this will be a bit of a different process than what you may have been familiar with in past years. Historically, behavior referrals have been routed to the special needs coordinators for service coordination and plan creation. And this year, they will be going to the mental health consultant. So referrals for behavioral support will be directed to us. And as with most things warranting referrals, the first step of the process is to recognize the need. So most frequently, the need is identified by a member of the teaching team and is then addressed in a monthly staffing or reflective consultation. That's not necessarily the way that it has to go. That's just the most common way that needs are recognized and addressed. As mentioned on a previous slide, the consultants will be visiting classrooms monthly, and so that's another opportunity to initiate the process in response to a concern. So however the concern is noticed and addressed, the referral is then entered for the child in COPA, and the mental health consultant will provide the data collection tools to the teaching team. This might be a DECA, it might be a behavior screener, it might be some other social emotional screener. It'll be based on whatever goals and needs that we are identifying and setting, and how we want to track our progress for the child. There may also be frequency charts provided, so that will indicate the intensity and severity of the behavior and the need for intervention. So after the data collection tools are provided, an observation will be conducted by the mental health consultant. And at that point, after data collection is completed, the observation is completed, the team will meet to review the data and observation notes and to develop the plan of support. So this team will consist of the consultant and a teacher, and additional people that may join are a supervisor, an early childhood coach, a special needs coordinator, the family advocate, and any other support staff as warranted. Following the creation of the plan, a parent conference will be hosted by the mental health consultant to ensure that there is adequate support of the plan on that end. Attendees of that meeting will be determined on a case-by-case basis. Finally, the plan will be implemented and the consultant will support the teaching team with any modeling, reflection, training, or modification that is needed. The plan will then be reviewed on a regular basis to assess the progress towards the goals. And if you have the handout with the flow chart, you can refer to that for a visual representation of this process. If you are someone who enters referrals into COPA, here's an example of what a behavior referral may look like. As you can see under referral reason, I've highlighted that behavior was chosen. And then under the options of who to refer to, in this case, we'll say that the child is enrolled at the Marib Center. And so that referral would go to the option with my name on it, since I do handle North County referrals primarily. Below that, you could type a brief summary of your observations or your comments on why the child is being referred for behavior support, and then submit the referral. Once the referral has been submitted, I will receive an email notification and then the follow-up will occur. To receive a mental health referral, a concern can be raised by a parent, a family advocate, a teacher. Typically, it will be in response to a change from the child's baseline behaviors or temperament, or a significant event that impacts the child. So it's important to note that these mental health referrals are for the child. They may involve the parent because, again, we know how critical relationship is to early childhood mental health, but these referrals are for the child. So because of the sensitive nature that could potentially surround this type of referral, the discussion about the need is handled based on the individual needs of the child or the family. So the appropriate staff will be invited for discussion and collecting pertinent information to then process the referral appropriately. After it has been deemed that a mental health referral is warranted, the referral can then be placed in COPA to the mental health consultant. At that point, the referral is then facilitated by the consultant to the mental health therapist or an appropriate community partner. If the services are conducted with the mental health therapist, they will do so in accordance with the treatment goals and mandates that are designated for this case. The services may take place on campus, at the family's home, or in the community. Services may be conducted with the child individually or with the family. These decisions are all made by the therapist based on the presenting problem and using their clinical judgment. The updates and feedback on the progress of the case are presented to the mental health consultant, again, on that individual need-to-know basis, and they will be shared when appropriate to the staff that may require that information. You may also, again, refer to the flow chart for mental health referrals for the visual depiction of this process. Here's another simple example of what this referral might look like. So again, you can see that the referral reason highlighted is mental health. There are other options that you could choose from if you wanted to get more specific, but this one's generally a good catch-all. And then in this example, we'll say that the child is enrolled at Northport, and so you would want to choose the early childhood mental health specialist South County option to refer to. Now, as I stated before, at this time, all referrals are going to be emailed to me, but then I will triage with the appropriate South County staff to make sure that child receives the services that they need. And again, you can write your observation or comments in the section provided below here, and then submit the referral. And then, of course, follow-up will occur as warranted. One of the unique services offered through early Head Start programs is the education and support provided to pregnant women who choose to pre-enroll in the program. Once the pre-enrolled baby has been born, Head Start performance standards mandate that a home visit is conducted within 2 weeks. At this home visit, The team of staff check in with the parent and conduct health and wellness screenings, as well as identify additional areas of support the parent or baby may need. Beginning during the COVID protocols, we began hosting these meetings virtually and with a mental health staff and health staff present. The current process will continue as we adhere to COVID safety protocols. So when a baby has been born, the family advocate will alert Champagne and Arianne, and the visit will then be scheduled. At the visit, I will administer the Edinburgh Postnatal Depression Scale to screen for postnatal depression or anxiety risk. Based on these findings or the discussion following this screening, a referral can be entered for the appropriate mental health support. Here is an example of what a newborn referral could look like. This is under the child's profile in COPA, as were the previous examples, because whatever support is offered is in service to the relationship between the mother and the child. In this example, let's say that the mother reported an increased risk for depression based on her Edinburgh scores. This can impact the attachment security between the baby and the mother, and so for that, this was an appropriate referral choice in COPA. For this example, let's say that the mother and child are pre-enrolled for our Ross Center, so the referral would be selected for me. The newborn cases can sometimes be tricky, so please don't ever hesitate to ask questions or gain clarity on a case that you may have questions about and wonder if it's appropriate for mental health support. I'm always happy to help triage those cases and figure out the best course of action for that family and that child. Additionally, beginning this year, children who are found to fall outside of their developmentally normative ranges on the ASQ Personal Social Domain or ASQ SE will be referred to our internal mental health supports for monitoring and follow-up. Once a referral has been received, the teachers and/or the family will be followed up with and offered support based on the targeted needs of that child. The child will then be monitored for progress using additional ASQ screenings, DECA, or other appropriate tools. The Director of Comprehensive Services, Wendy Harris, has created an in-depth training regarding the full ASQ administration and referral process. Please refer to that training for additional details. So this will conclude the presentation on the overview of mental health support services and referral processes. If at any point you wish to have more information or have any questions after processing this information, please do reach out to me. I really do enjoy hearing from everyone and helping to field questions and find answers. I wanted to leave us with this quote from Becky Bailey, which states, "The quality of the interactions and relationships we have with children is the main determinant of optimal development and impacts us the rest of our lives." One of the most profound takeaways about child mental health is the importance of the relationship quality. We can always benefit from self-reflection and personal growth to better serve the children in our care. And as promised, here is my contact information for those inquiries or comments regarding any materials covered today. Please feel free to email me or call me at my extension so that we can discuss any questions or concerns you may have. I do appreciate your time and attention to these topics, and I'm looking forward to working together this year.